We often hear the negatives about the NHS, but I just want to make it clear that I am really an optimist about the NHS. I think it is just a very exciting place. You've heard from Glenn and you heard yesterday some of the really good things going on. There are a lot of really very good things going on. But I think the point I want to make today is just to focus on patient safety and what perhaps is one of the big barriers to getting patient safety right, and the real opportunities for us in the NHS to drive patient safety forward. When this report came out, this was 1999, 20 years ago, I thought it was a breakthrough report. It changed the thinking about safety dramatically. You may all be aware of it, you may have read it, you'll know the messages in it. It was perhaps the first report to emphasize that medical errors, it's an American report, so they don't call them patient safety incidents, they call them medical errors, are a very important cause of harm in healthcare systems. And it's important that we recognise that patient safety is not a UK problem, it's not an NHS problem, it's a problem healthcare worldwide. And the issues we're talking about are worldwide healthcare issues. These were in the States. They shockingly announced that they thought 44,000 Americans died every year because of medical errors. That was shocking at the time, but it's since become clear that was a significant underestimate. That it's much larger than that. And of course, similar figures apply in this country and in other developed healthcare economies. And they said that the cause of this are faulty systems. Blaming the individual is not the answer. You've got to design systems that enable the individual to be protected against mistakes. And Glenn was just talking about one about nasogastric tube there, a great example of designing a system to prevent people making an error, which we know they can make. And for too long, we've taken the view that the way for patient safety is for people not to make mistakes. We've got to understand that people make mistakes all the time, and we need to design patient safety around that understanding. And of course, it says at the end there that blaming the individual is of no benefit. All it does is create defensive reaction to the error and stops us learning from it and stops us moving forward. Now, these are messages we've been hearing consistently for the last 20 years since this report came out. But I would challenge you to say, have we made the progress we should have made? And my view of that is we haven't. So these messages are important, but they are not really changing things and moving things forward. Another report that came out only 6 years ago, this is just in the aftermath of Mid-Stats, in this case it's an English report about the English NHS, a promise to learn, a commitment to act. And this really had the same messages. We need to be a learning organisation. We need to recognise that blaming individuals is counterproductive and just leads to denial and fear. And this report very rememberably said we must abolish fear from the NHS. So absolutely right. You can't fail to support that. But that was 6 years ago. A promise to learn, a commitment to act. Well, have we learned and have we acted? And I would challenge you to say perhaps we have not learned or acted enough. So we haven't moved forward as we wanted to then, and I'm sure many of you are enthusiastic about that report and learnt on it. And it's not just other people, it's CQC as well. We produced this report in 2017. It was a report on our first inspections across the NHS. We completed all acute hospitals and we produced this report. And we said that there was a problem with patient safety culture. And we said patient safety has to be everyone's responsibility. We wouldn't deny that. And we have to create a learning culture. We have to create a just culture where people aren't blamed. We were saying exactly the same as those previous two reports. And I have to say, I wrote most of this, and I really feel that we didn't really have anything new to say and no sense about how we change that culture. And I suppose what I want to talk to you today about is how do we change that culture so some of those ambitions can actually be delivered. As I said earlier on, the health service is moving forward. And we've seen a lot of improvement across healthcare providers across England. And we've identified some of the things that drive that improvement. It's a changed view of leadership. If you like, moving on from the top-down leadership, this is so traditional of the NHS, to one of a distributed collaborative leadership which recognises that improvement is driven by engaging and empowering staff, not by telling them what to do. It's a leadership that drives openness and transparency and recognises that by being open about issues, you're much more likely to resolve them than by keeping them hidden. And by being transparent, we're being honest with ourselves and with the people we serve. It's about having effective governance, absolutely right. Governance is not a paper exercise, it is about running the service effectively and driving safety and quality. And we've increasingly identified those organisations as making real moves forward have developed a culture of continuous quality improvement driven from the front line, not from the top of the organisation, but driven from the front line. If you want to read more about what we've found, those organisations that have improved, it's in these reports, one there for acute trust, one for mental health trusts, and it is in their own words. We at the CQCs don't say we've got the answers, it's just we know some people who have, and we are quoting them in these reports. So please do look at them if you haven't already seen them. And that is driving real improvements. So the state of care last year, we highlighted where we've got to, both in acute and mental health services. And now, 2/3 of services we inspect in NHS trusts are good or outstanding. Now, when we started this 5 years ago, 2/3 were requires improvement or inadequate. There has been a major change. Nowadays, if you're a requires improvement service, you are in the minority. If you're an adequate service, you're in a very small minority. The majority of services have driven real improvement, and that is having a real impact on the quality of care that patients are receiving. And that's really important to recognise. But I think we should also recognise that while the quality of care is improving, safety is the one area we haven't seen the improvement we'd like to see. And we are still seeing that approximately 40% of trusts, 40% of services are either requires improvement or inadequate for safety. And that has hardly moved over the years. So safety remains our biggest concern, and it is not moving as it should. So this comes back to my point. We know what to do, we know what we ought to be achieving, but we aren't delivering it. What are the barriers that are holding us back? And this comes to the report that we published just before Christmas on never events. Now, never events, as I'm sure many of you know, are events, patient safety events, that are meant to be preventable. There are well-tried and tested methods of preventing them occurring, and yet they keep occurring. And over the last nearly a decade now that never events have been measured, they have hardly changed in incidence at all. And this is very strange because individual organisations sometimes think they've got the answer to never events. They have a run of never events and they take some action and the never events go away. And they think they've solved it. And if they've solved it, why cannot everyone else solve it? But then if you watch very carefully, you'll find a year or two later, they start having never events again. And have they really solved it? No, they haven't. There are only about 500 never events a year, which is on average 2 per NHS trust. And so just by statistical variation, you'll have runs, and then you'll stop, and then you'll have other runs. And so people believe they've made a difference, when in actual fact, they haven't really changed anything fundamental. And this is the great problem with this. And what never events, this persistent level of never events is telling us is that fundamentally we are not making the difference we want to make patients safer. And never events are only 500, but the principles that prevent never events are also the principles that prevent all the other safety events, the 21,000 serious incidents and the nearly 2 million other patient safety incidents that are reported every year. So if we can learn to crack never events and understand what's going on there, we can then learn to address the much wider patient safety issues. Now, last week I was in an operating theatre in a hospital I was visiting and talking to a vascular surgeon. He had recently had a never event. He put a stent in the aorta and had put the wrong stent in. So he's one of the 64 wrong implant prostheses never events. And he showed me the package of the stent that he'd put in and the package of the stent he intended to put in, and to an untrained eye, they looked virtually identical. If you read the small print on the label, you could see there were different stents, but actually it was very difficult. It was very difficult for someone pulling the stent off a shelf to realise that. There was a barcode there, but of course they hadn't used it. Now, he told me that they'd introduced some new checking procedures and he was confident they wouldn't make that same mistake again. And I bet he was right. I bet he was right. Because the great truth about never events is you never make the same mistake again. You just make a different mistake that has similar characteristics to the previous one. So he won't put the wrong stent in again, but perhaps someone in the next door theatre could put in the wrong hip prosthesis, or in the theatre down the line put in the wrong lens in someone's eye, because those are very common never events. So while they had learnt to prevent putting in the wrong stent, they hadn't learnt the underlying problem, which was how do you avoid putting in the wrong prosthesis? And as I say, those are common issues. Wrong site surgery, it's about 200 of those a year. Well, surely we should be able to stop ourselves operating on the wrong site, or occasionally even the wrong patient, by getting the proper identification of patients and identifying and tying them into the operation we intended. Glenn mentioned the misplaced nasogastric tubes, and I have to say that is one area that I'm really concerned about. We know nasogastric tubes, which is an everyday event on the wards, are actually highly dangerous. They are high risk, but do we recognise that when we put them in? And do the people who are putting them in understand their high risk? I'll just explain a story that comes in our never event review about nasogastric tubes. An organisation had a never event, and they couldn't understand, with a nasogastric tube misplaced, put into the trachea instead of the esophagus, and the patient died. They couldn't understand why this had happened, because they trained their staff. And we asked them about training the staff. All the nurses had been through very detailed training. But the junior doctors hadn't, because the junior doctors, of course, are trained anyway. They don't need to be trained because they're the experts. And it's the junior doctors that oversee putting in the nasogastric tube and check they're in the right place. And the nurses, even though they're trained, don't feel they can challenge the junior doctors, even though the nurses are probably more expert than the junior doctors in putting it in. And that characterises one of the things we found, that actually hierarchies and interprofessional relationships are actually a real bar to safety. People don't think they can challenge. And so many of these events are about, we hear that the junior member of the staff knows what is happening, but cannot challenge. Why can they not challenge? It's very easy for us to say to them, you must challenge, but it's not that simple. And let me explain why. So in our finding on never events, we found that never events continue, despite the staff being very committed to safety. Why is this happening? Because the culture in which they work does not support them taking the right action. We need a fundamental change in culture at the front line to allow staff to take the right action to improve safety. I mean, the staff told us that they face ever-increasing patient demand. That leaves little time for safety training, for guidance to be followed, and guidance is not given, safety is not given the priority that they think is important. They told us that they work in hierarchical structures where it is difficult to challenge, difficult for juniors to raise concerns. And they told us that the many patient safety alerts that seem to arrive numerously every day in NHS trusts just feel like a bureaucratic exercise rather than something that is really focused on driving patient safety. We've got to do better on this. So one of the things that we are doing, and this is fed very much into the patient safety strategy that is being developed at the moment, which is, I think, going to be very important in that regard, is we've got to learn how we interact both nationally and locally to make sure the right patient safety priorities are prioritised. Trusts receive multiple messages, and the coordination between central bodies is often quite mixed. We've now set up a committee where all the bodies that issue patient safety alerts meet together, and we're trying to prioritise them so the messages coming out are much clearer to trusts and the priorities are much clearer. And we need to understand how the different parts of the system react together. It was very interesting talking to NHS trusts and their relationship to their local clinical commissioning group. Some trusts, when they had a never event, found their local clinical commissioning group was really very supportive and helped them understand what was going on. But others, the CCG, got into a kind of performance management mode and held them to account, to use that terrible term that causes so much anguish in the NHS. How do we make sure that when someone has a patient safety event, the system supports them in finding the solution, rather than, if you like, penalises them for getting something wrong? And if we don't get that right, how can we expect we treat individual staff appropriately when things go wrong? And the bottom bullet point here, I think, is really very important as well, and that is involving patients and relatives in learning from safety events. We just published a report on learning from deaths. And this report was based upon what we've observed about the learning from death guidance introduced in NHS trusts over the last few years. And what we found is a lot of good practice, but the weakest area is still the ability to involve families in how organisations learn from deaths. There is really still a sense of defensiveness about involving families. And yet the families want to be involved, need to be involved, and the evidence suggests if you involve them, you get better understanding of the reasons that errors have been made. So how can we crack that one? And how do we move away from this defensive stand? Let me perhaps move on to what I think is the fundamental issue here. When we did our Never Events review, we asked other industries, aviation, oil industry, offshore oil industry, nuclear industry, to come and tell us about how they approach safety. And it was very interesting to have these clinicians in the room talking about patient safety, which was their expertise, or they regarded their expertise, and these other patient safety experts from other industries talking together. And they talked very differently. The clinicians expressed how difficult it was. They mentioned some of the things I've already highlighted. We're very busy. Workload is very hard. We work under pressure. And I remember one surgeon saying, you just don't understand. We work under enormous pressure. And if we don't get the operations done, we get into trouble. And there was a captain from BA there talking about it. And he said, look, I work under pressure too. If I am, a few minutes late off the stand when we take off, I will get held to account for that. But I would never move the plane unless it was safe to do so. And so there's a kind of sense of the two organisations, the two industries think very differently about risk. Those industries that are risk aware and have got this right recognise right from the word go that priority of patient safety is absolute. It's not negotiable. It's not something that's elastic if you're working under pressure. And yet in healthcare we still have that view. We're too busy to get safety right. And we've seen a lot of that. I mean, one of the things that I've been pushing really hard over the last year or so is safety in emergency departments. Now, we all know emergency departments are working under intense pressure at the moment. We recognise that. But when you're working under intense pressure, that's when you've got to get safety right. It is not the time to let safety slip. And in those industries, it's interesting they talk about safety training. Now, when I go to trust and talk about safety training, it usually is called mandatory training, and people regard it as a bureaucratic exercise. They'll often put it on a kind of web package, so it can be done in people's private time rather than their work time. And it's regarded as a kind of performance management. How many have you done? Tick, tick, tick. These industries said, well, actually, safety is the first thing we train new people coming into our industry. If they can't do safety, they can't learn anything else. So the first thing they do is go on a safety training course where they learn about human factors and how people make errors in their interactions with one another. They learn about situational awareness and how you can get very narrowly focused on what's in front of you and forget the bigger picture. They learn about team dynamics, and they learn that hierarchies within teams are extremely dangerous. And that actually the team has to work to make sure that the hierarchy does not get in the way. And that means everyone in the team needs to recognise that hierarchy can lead to mistakes being made. We don't have those discussions in healthcare. We accept hierarchies as the natural way of things. We expect professional silos to be there, and we don't challenge them. But certainly in my experience in inspecting hospitals, we often see that those are just the things that get in the way of safety. The other thing is safety protocols. They're not negotiable. In the high-risk industries, they are always done. The idea that, and it was very interesting because there's a surgeon who was talking about the WHO safety surgical checklist and was saying, well, in my trust, I try and do it most of the time, but some of my colleagues don't. And there was someone there from the nuclear industry who said, well, why are they allowed to operate then? Why are they allowed to operate if they don't do the safety checklist? Why have we got to a position where it's acceptable for people not to do the safety checklist, which we know saves lives and reduces safety incidents? And technology is used where appropriate to drive safety, for identification, for standardisation, and to highlight potential errors, as Glenn highlighted earlier. Technology is used as a tool to help. It is not the answer, but if you get the right culture, it can be a real valuable tool to drive safety cultures. And it is accepted and used as such. So what is the answer? Well, the answer is we need to change the culture. In the report we published just before Christmas, it's called Opening the Door to Change. It's available on the web. do have a look at it. It's got the recommendations we made in there. But these are, if you like, the highlights of that. Well, first of all, we've got to recognise that everyone needs to be part of safety. Yes, absolutely. We've said that before. But they need to have an understanding of safety. We found that often the safety lead in organisations doesn't actually have any expertise in safety. They may be a clinician, but the fact you're a clinician doesn't mean you're an expert on safety. There's an assumption that clinicians are automatically experts on safety. But actually, being an expert on safety is very different from that. It is understanding about human factors. It's understanding about risk management. It is understanding about situational awareness and hierarchies and how they get in the way of safety. And that expertise is often not present in healthcare organisations. The assumption is that safety is all about clinical understanding, when it isn't. It's often about how humans interact. When we looked at never events, we found that 4% of them had straightforward technical solutions. 96% of them required different human-human interactions to be prevented. So human-human interactions, human factors, absolutely fundamental to driving safety, and yet we don't value that as expertise. So we need to make sure that expertise is available in all organisations and everyone understands it and is involved in it. There's another point here, and that is the cultural change has to have humility to it. There's a real sense that in healthcare we have to claim to be perfect. We have to claim to be getting everything right. But actually we've got to start recognising that we're all fallible and errors are going to occur. And what our duty is not to deny the presence of errors, but to minimise the incidence of errors. And I think this may be one of the issues why it's so difficult for some healthcare to interact with patients and families after errors. Because an error is seen as a failure. An error is seen as a failure of healthcare, failure of the individual or failure of the organisation. But actually, if we accept errors as a part of everything we do, and therefore something we need to learn from, and don't, if you like, sell ourselves to patients as being infallible, then we may be in a position where we can have much more productive involvement of patients and families when things go wrong. And by involving them, we can drive forward learning much better. So there is what I think is necessary, a major change in culture. We've got to start thinking like a high-risk industry. They have shown the way. 20 years ago, or 25 years ago, they were saying, we are where you were. But we've moved, we've changed. And if you look at those industries and how they've driven safety, it is quite dramatic. 20 years ago, we had the report to err is human. And I don't think we've changed enough. I think now is the opportunity for us to drive forward that change. Thank you very much.